Hello, welcome everyone to tonight's webinar on Class 2 restorations. It's called That's My MO. We're going to be covering a lot of different things here, and I'm super excited to have everyone with us. I've got a few new products that I'm really excited to share with you that have just come out on the market that I'm using at my office that have really revolutionized the way that I've done Class 2 restorations. And I think the Class 2 restoration on a primary tooth, honestly, is probably one of the hardest things we do in dentistry. And it's just so difficult. And I know you struggle with it at your office. I have too. And I've gotten a lot better at it. And some of the technology that's come out to help us has really, really improved my results at my office over the past year. And we'll cover some of those products. And I think there's some challenges and opportunities that we have with our patients that I think we all can improve together. And that's just where I'm in my journey. And as many of you know, I got a microscope in my office this year, and that's just really improved my visualization and what I can see. And some of the things I wasn't seeing probably had some results to my failures in the past. So if you have any questions tonight, please go ahead and drop them in the Q&A or in the chat. We'll try to get to those. This is being recorded as well, so we'll be able to replay this. I'm going to try to stick to an hour. We've probably got a little more content than that, but I'll try to be honoring your time. As far as certificate for CE, we will email that to you here within a week. And if you registered and you submitted your AEGD number, we're going to go ahead and get that credit uploaded to you so you can have that towards your fellow or master's track. So we appreciate you participating in that program and excelling with the AGD. I do have to disclose that tonight, let's see here. There we go. So we're moving forward. Tonight, there is an honorarium that I am receiving from Octodent, and that has helped support this webinar tonight, as well as a podcast and some other content that's going to be coming out. So just keep that in mind as we move forward with discussing everything tonight. There are some differences. The first thing I want to talk about, I didn't cover this in the objectives, but anatomy is so different with these teeth. Primary teeth, they start developing in utero, and that can be impacted by a lot of different things. I know my wife, with our youngest son here, I mean, she had a miserable time with COVID when she was pregnant. I mean, it knocked her out. And there's teeth have to develop at a certain temperature for those ameloblasts to be able to lay down that hydroxyapatite. And it just sometimes we have things affected. I think we see commonly in primary teeth, we probably see more the second molars affected. And then we also see this with the permanent dentition with hypoplastic molar, MIH, molar incisal hypoplasia. So keeping that in mind, that the primary teeth develop in utero in such a short amount of time, that's just a few months, and they're already erupting at 6 months, versus a permanent tooth has about 2 to 3 years to develop that enamel matrix, and then it continues to develop the dentin and the roots, and then erupts 6 years later. So completely different things that we're talking about. But some of the differences here are, number one, the enamel thickness. We know that our primary teeth are just they're not as thick. And I think that's part of just biology and evolution. And they're not meant to be there forever. They're meant to serve a purpose to get that child to have nutrition. They need to have teeth to be able to eat and get those in faster. And then once those are gone, we can move into something that's a little bit more developed, a little bit stronger, like we just talked about. And that enamel thickness is really important when we look at our bonding agents, because that's really, when we're talking composite, that's really what we're looking at bonding to. Here, again, our dentin thickness is going to be a little bit different than a permanent tooth. We're going to have a little bit difference in that. And I think also you got to think about the collagen and the hard and the matrix that we're going to have. So collagen is going to be something that's going to be more prominent in a primary tooth, and then we're going to have more mineral in a permanent tooth. So thinking again of these bonding agents, these composites, what are we thinking as a restorative material, especially in a high-risk kid? And then you may be challenged with a kid with bruxism, and that may not be something you want to put a glass ionomer in. We'll cover that a little bit here tonight as well. The pulp chamber is going to be a little bit larger. Here you can see compared to the permanent tooth. So we're going to have higher pulp horns. And when we're looking at these class 2s, I know we all talk about first molars. Oh my goodness, those are like the nightmare to do class twos on because the pulp horn is just so high and you drop your box, and sometimes unfortunately we end up in a place we don't really want to be. So keeping a conservative prep and then also having enough room for the restorative material is a huge challenge for us. And your preparation design is going to be really important to help give you that extra attention. So if you're doing a composite, you're getting the extra attention, so you're not having these fracture and break on you. You can see we're going to have a bigger cervical bulge on the primary tooth. This is great for our stainless steel crowns. We love this in most cases to provide a little extra attention, but in some cases it can be a hindrance too, especially on those first molars when we're looking at doing a stainless steel crown. Enamel rods are actually going to run in the opposite direction, and this can weaken the tooth if we're doing like a reverse S-curve. So keeping that in mind when we do our preparation designs, and not trying to have that reverse S-curve when we go out and extend into the occlusal surface that we're doing. We're going to have a cervical constriction that's going to be greater in the primary tooth, and that is something that you want to be considerate about. I think one of the hardest things is when you drop your box, if you have to level up or move more towards the pulp, sometimes you can run into that cervical constriction. All of a sudden, you're just looking down at a bunch of gingiva and blood, and you're just like, oh my gosh, how did we get here? So something that can be beneficial with that is wedging, and the wedges that we're going to show you tonight with some of the products that we have can really be a huge benefit if you run into a challenging situation where you have deep decay. And then the roots are going to be a little more flared out. We know that the adult tooth develops in the lower jaw, lingual to the tooth, and then underneath the root. So we got to have room for that. So our roots are going to be a little more flaring. This can be a little more challenging with extractions, but probably not going to really impact us with our class 2 restorations that we're going to be doing. And then our crown to root ratio is going to be a little bit different. Here you can see a difference in we have got a different in crown to root ratio with the adult tooth. Let's see. Okay, we had a few questions come through, but they're more about the recording. So yes, this will be recorded. Again, here's your list. If you wanted that laundry list that I just scrolled through, I'm just going to move on from this. Some of the materials that are popular these days, amalgam was tried and true for a long time. That's probably been the most traditional material that we've had in the past century. And I think a lot of people are moving away from that. A lot of parents are concerned about mercury and health with their kids. And I think that's rightly so. I know there's just that new study out from the National Toxicity with Fluoride, and we have that now to address at our offices. And I think the ADA is doing a great job of providing you with resources to doing that. Those studies were almost 2 times the amount of recommended fluoride, with the IQ getting lower than what we have now. And I think we have solid evidence, and we need to really be evaluating this all the time. And I'm excited that we're in a place where things are constantly being evaluated. The amalgam, we probably at my office more use this when a parent comes in and they don't want to pay the extra for the white. They want to do what their insurance covers. And so we still have it. I know we used to use Titan a lot from Dentsply. That has been discontinued. I use another product now that has a copper alloy that is from SDI. It's called Logic. It's a similar one. The copper increases the setting time of the alloy. So if you're working on a kid, we're going to have a faster procedure time. And that's key when we're working on some of these young, squirrely kids that we just want to get in and out of the chair and make sure they have a positive experience at our office. Composite is another popular item. I was steered away from this a lot. When I opened my office, I saw about 70% Medicaid. And obviously, there's a big challenge when you have a high-risk kid and you're trying to place class 2 composites. I got burned quite a bit early in my career, and kind of steered more towards RMGIs and GIs. They have downfalls too, but they don't get recurrent decay. We're more repairing something and fixing something than doing a pulpotomy and a crown after that. And then we'll not cover the comprimers, but I know a lot of people use Dirax. That's another material you may want to consider at your office. I don't have a lot of experience with it, but it is kind of a cross between a glass ionomer and a composite. Here again, amalgam, this is just great because you don't need great isolation. Everything's going to be with this mechanical retention. It has the silver in it that's going to be able to provide that passivation layer to prevent recurrent decay. And honestly, like I said, we don't do this a ton. One of the problems in primary teeth is your ideal depth is 2 millimeters. And by that point, unfortunately, in some kids, you're already into the pulp. And that can be a problem. Minimal thickness is 1.5 millimeters. And the preparation really needs to be bulky. It needs to be boxy so you don't have these fracture. I remember I started placing these. I was trying to be a little more conservative than I should initially in my career. And I ended up having to redo a lot of these because I didn't have the preparation designed correctly. And we had to move on to making that bigger and deeper or doing a stainless steel crown on some kids. Obviously, it's going to have a good strength. And then again, you're going to have mechanical retention here. This is a permanent tooth, but here you can see that's the Logic product. That's there. I'm going to move through bonding agents a little bit just for time, seeing that we're already about 12 minutes in. Composite, I think this is, for me, I'm really excited about some of the new composite materials that are on the market. For me, this was something I steered away from. I remember we had some high-risk kids that came through and the parents really wanted to avoid that stainless steel crown and do an all-white filling. And I did a lot of class 2 composites on these kids and they ended up coming back and they had recurrent decay and I had to redo them again. And they weren't the most cooperative and it really, really hurt me. And I think it's something that we need to use our judgment on. We have that. What do you do if you have that high-risk kid that is a bruxer? We know that the GI and the RMGI are going to wear down. Do we take that or do we do the composite? Those are kind of some challenges that I faced at my office on material selection. And I don't think there's a right answer, but I think some of the newer materials have gotten me a little bit excited that we've been using at my office for over a year now. It's going to be more aesthetic. You're not going to get that yellowing or grain you get with the RMGI. You can do a conservative prep. You can do a slot prep with a little bit of mechanical retention, which is a little more conservative than extension for prevention. And then you can seal the rest of the tooth. To be honest, you really got to have good isolation. Isolite, Dry Shield, Mr. Thirsty, or Rubber Dam are going to be your best friends to be able to keep these. And it does take you a little more time than a GI or RMGI. You're going to have to etch and bond, curing light after that, and then maybe incrementally layer the composite. Then now we have new composites on the market that have unlimited depth of cure, which is amazing, and they don't even need a curing light. So I'm excited to share with you that one of those products tonight. With the two different types, I think a lot of pediatric dentists that I know are using flowable composite for their class 2s, which works really great with some matrix systems that are out there. They aren't as well filled, so they're going to wear a little bit more. But again, with these primary teeth, we're not needing them to last an eternity like a permanent tooth. So I think that's a good solution. If you want to go ahead and use a packable composite, those are great as well. You're gonna have a better wear resistance, especially if you have a kid that's grinding their teeth. I know there's a lot of information out there coming out about airway and bruxism, and that's one of the things we ask questions about when we have kids that are grinding their teeth. We ask about snoring at night, bedwetting. Those kind of things lead into more of an airway conversation that we may want to have a conversation with their pediatrician or primary healthcare provider or their ENT and make that referral to address any airway concerns so that they can avoid having sleep apnea throughout the night. Composite contraindications, obviously, if you can't get good isolation, you're probably not going to want to use a composite where you can't etch and bond and cure and then place your composite. It just is not going to be a good situation if you have that leakage and then all of a sudden the kids lost the restoration, they're getting food impacted, and then we're redoing this and we have a bigger problem with a stainless steel crown and the pulpotomy. We just want to try to avoid that. If we get into trouble, a lot of times I'm doing just a GI and we're putting a temporary in, letting the parents know, and we're coming back to do sedation or coming back to hopefully work with the kid and then fight another day to take care of that tooth. High-risk kids, unless they're a bruxer, I would probably try to limit the use of it in posterior class 2s. I just think these high-risk kids, I've seen so many of them come back where we've done extensive work and composite leaks. There's a gap in the margin, and if they don't change their habits at home, we don't get on a solid prevention plan, at our office with adequate medicine that we're putting on the teeth, we can run into some issues of doing work over and over again. And our goal as pediatric dentists and general dentists treating kids is to be able to have that tooth treated once and be done. That's my goal, is to not have to work on a tooth twice. Unfortunately, we can't do that all the time, but if we can aspire to make that goal, I think it's going to be a great service to your office and your patients to have these families that come in with a bunch of cavities. And the best conversation is, oh my gosh, you had 8 cavities when you come in, you haven't had any for 5 years now. Isn't that the best feeling as a pediatric dentist? I think that's something I pride myself in when we have those conversations with our families of great outcomes with it. Our restorative technique. And again, if they have poor oral hygiene, you may not be able to get good isolation. I think we've all had those patients that we've taken to the OR and they're special healthcare needs, and it's just very difficult to even get isolation. And you just brush all that plaque off and there's just bleeding everywhere, and you're not able to get that stopped adequately to do a good job. I think those are some times you may want to consider an alternative material, an RMGI, if it's an aesthetic zone, or a GI if you're really having trouble with isolation. Bioactives got really popular. I think there was a big Activa push a few years ago. And I think this is something that we should really pay attention to. I think we will see a lot more advancement with bioactives. And I think it's a huge plus to have materials that can absorb fluoride, calcium, and phosphate and release that back and forth with the tooth structure, as well as maintain tooth integrity. I think some of these materials got burned. I think Activia got burned when they came out. They said, well, you don't need to do any bonding agent. And then they come out and they came back with their IFUs and they reviewed them and they said, well, you actually do need to do a bonding agent. So I would just take this with the caution, but take some excitement to it, because I think it's an area that we can advance with if we look at these materials, and they can interact with the tooth and remineralize the tooth and provide a better interface, so we're not getting recurrent decay and we're not having some of the challenges with wear that we have with GIs and RMGIs. Again, ways to combat microleakage. First and foremost, if you have not gone and listened to the dentist dad, Roger Lucas, like, you have to have a conversation about diet with all of your patients that are high risk. And you have to, be motivational interviewing. You have to be asking the patients, like, what do you think is causing the cavities? That's the first thing I ask. And if they don't have a clue, then we dive into some more different types of questions about what they're eating and snacking on. And we hope to find something that we can really discover. Usually it's crackers or chips. A lot of parents don't realize that they're 7 times stickier than bread, and that your amylase breaks down a carbohydrate to sugar in your mouth. And if the kids are having that sit there all day and snacking on that all day, we're going to have problems. Another thing you can work on is, we've made a really big push on prevention at my office. There are therapeutics out there for kids that are over 6. You can put them on a prescription toothpaste with more fluoride. There's so many different therapeutics out there now that we'll find out more about. There's probiotics out there that have shown some success, depending on the study that you look at. And then the povidone iodine is another great tool. One of the problems with these is, once you stop using it, you lose the effect of it and everything comes back. So it's important to have that continual conversation about prevention at your office to be able to maintain the work and protect the investment that your patients are making in their mouths. Alternatives you may want to just also consider. I know sometimes it stinks if you have a Brexer, they're high risk and they don't want the silver, and that glass ionomer is going to wear down, it's going to wash out over time. Maybe you just have that conversation that, yeah, this is an alternative, but we probably will have to have some more maintenance with it, and we may need to repair that in 2 to 4 years. That might be something that you accept to be able to go ahead and meet the patient where they are, to meet them on their journey. Let's see. So again, Activia, bioactive, restorative. I think I called it the yogurt earlier, so I apologize to Pulp Dent for that. But it's a kind of a gap. It's kind of like what a Compomer would be. They release fluoride, calcium, and phosphate, and that helps remineralize the tooth structure. And I think when you do treat this like a composite and etch and bond, it can be a great restorative material for your patients. Here you can see if you look at a surface deposition analysis, this is done to Tufts University. You can see a higher concentration of calcium and phosphate here at 14 days and 28 days compared with the control. If we look here at testing again with fluoride, greater fluoride release, uptake, and recharge compared to the control. This is from the AADR in 2014. And again, it goes through the bonding agent too. It's the bonding agent is not going to protect or prevent that fluoride uptake. So that can be a benefit. It also is going to have a higher strength compared to an RMGI, and that's going to give you a little more leeway here when you're looking at these kids that may be a higher risk, but also may have some of those candidates where they're maybe doing a little more bruxism on the teeth. I think, again, this is where they got burned here, is that you can just go ahead and have mechanical retention in places. I think that's where I had a lot of issues with this product in the past, and you can be successful with it. This is probably something here where you, in this case, you would probably want to go ahead and place a stainless steel crown. And here you can see after preparation, we can get a nice result with the pulp dent product. And I think a lot of companies are looking at these bioactives and becoming more active in trying to figure out how we can make this work for our patients, because I think there is a huge benefit to remineralizing the tooth and preventing recurrent decay. And glass ionomers do such a good job with that, but they have such a poor strength compared to composite. I've used this product before, Surefill 1. This is a self-adhesive composite hybrid. So it's essentially your bonding agent and a flowable composite mixed together in a capsule. And I've used it for a while. I did like this product, but you do have to treat it like a composite. And it does have a 5-minute set time. So when we look at kids in pediatrics, that may be something that may not be the appetite that you want to have, especially if you've got a 4-year-old sitting in the chair and they're just not having the appointment. This may not be something that you want to use, but I did like this product. I did have great results with this, and it's nice to not have fewer steps. And typically we would use this on an older kid. We'd go ahead and prepare it, place our matrix, I'd place the composite, and then walk away and come back and after a hygiene check. But it was a great product to use. This is a newer one that is kind of similar. This one I was one of the first to use this here in the US working with SDI, and I really have enjoyed working with this product, Stella. This is a composite, but it's self-cure. So it's great for most clinical situations. What got me excited is some of the stuff I'm going to show you with the gap-free interface. I'd love to see a dye leakage study with it. I've asked for that. We'll see if that will come out. But it's 2 simple steps. You have a primer after the preparation, and you place it, and you're done. You let it cure. You don't even need a curing light, and it just cuts down on the number of the steps. You don't have to do the 20-second etch. Then you have to do the bonding agent. Then you have to do the cure, and then you have to cure your composite. It's just all in one, and it's an unlimited depth to cure. The primer has MDP in it, which has been a little bit of a challenge when we're doing back-to-back matrices. They will get stuck. You won't be able to remove them without a hemostat. That's how well this bonds to the metal matrix and as well as the tooth. And then again, we're seeing some of these bioactive properties with the fluoride and calcium release with this product. I prefer the syringes. I know not everyone has a titrator. Some people will prefer to have the automic syringe. That can be great for your office. I think it can be great for moving dentistry forward in other countries as well. The name came from this Peruvian stone, which, I mean, this is 700 years ago. Could you think of carving all these blocks to fit together? I mean, that's just incredible that this stuff is still standing today. You look at stuff we make today and it falls apart. I mean, structures and things come down, and this is 700 years old, and the gap-free interface is what this comes from. And they want a strong material, but we also want to have that nice interface. So this is microscopy of Stella, trying to draw off that. That's where they got the name of that primer being able to bond that composite into the tooth. And if this is doing what it's doing with micro leakage, I think it's what excites me about maybe using that composite in a higher risk kid. And I've kind of pushed things a little bit more than I probably have done. I've had some kids that are high risk that have done great, and I've had a few that have come back that it hasn't been. So I'll keep you updated on this, but I think this product, I love using it. I love not having to have that wear of the glass ionomer that we've been having and have to redo those ditched out restorations on some of these parents that are more concerned about aesthetics. The viscosity is also nice for placing this. I'll say the capsules are probably a little more viscosity or thicker. So that can be something you may want to concern. If you really want to flow something into area, I would go with the auto mix on this one. But you have both options. I have both at my office. They both are consistent in different situations. If you have like a deeper preparation, the auto mix is going to be better for you. That tip is going to be thin. It can bend in any direction that you'd like to be able to place this more conveniently. The capsule is going to be a little more difficult if you have a larger preparation, such as a permanent molar where you've got deep caries and you're trying to elevate that margin up and have that depth of thickness. You're probably going to want to go with the auto mix and use that. It's a universal shade. So I think from the kids that we see, I don't think you're going to have an issue with matching a shade from these kids. You might have an issue with an older adult, but that's not the population that I'm treating. I think you can even match an A1. I'll tell you, they say A2 and A3, but an A1, which is kind of where we are with the kids in A1 or a B1. A lot of people or assistants get upset about the extrusion. You can see it's not going to be, I don't have that issue. I've got big hands, but some people get concerned about the extrusion and the force it requires. It's going to be less than your other GIs and RMGIs, if that's a concern for you. Again, it's 2 simple steps: a primer, air dry, and then go ahead and place in your composite. And it sets in about 120 seconds is what I've seen. You can remove your matrix. They don't want you to finish it for 4 minutes, but I've been able to get away with finishing it sooner than that. Again, you're going to go ahead and apply the primer here, leave it for 5 seconds and then air dry like you would a traditional bonding agent, and then overfill the cavity, and then go ahead and remove excess, and then wait for 4 minutes. Again, after 120 seconds, you can remove your matrix and go ahead and start finishing if you want. If you want to have ideal finishing properties for an anterior one, I'd wait 4 minutes. Again, you can see the difference in time of all these steps. 15 seconds to restoration. And then a lot of people think that 120 seconds is going to be a long time, but it's not really any longer than what you're sitting already with all the other steps you're doing. And I think you can have a better outcome and a better result for your patients by just being able to not have stuff in their mouth, not trying to do so many different things and keep it dry. It's done in 15 seconds. And then the set time, it's already there. You're just protecting it. I think it's going to be a great product, especially with the auto mix for use in missionary trips and things. You can use it for a lot of different indications. One of the ones that's not on here is a strip crown. I have had great luck with the Hall crown strip crown with this compared to the glass ionomer and RMGI strip crowns. Just placing the primer in 5 seconds and then throwing that on, I'm not having these break. And I've done a handful of these here, and I'm just having such better success. Parents are less frustrated. We just had a kid in this week at my office that had her GI strip crown break off for the 3rd time, and we just replaced it with the Stella one. And I don't think she's going to have the issue that we had in the past. You're not going to have shrinkage from this, from the light curing. This cures from within and forms a matrix web. And then if this is what this is doing, I think we're going to have a better result compared to the composite. So you can here see another composite, a self-etch adhesive, and then an etch and rinse. And you can see the gap that forms. And that's why composites leak. They're on these high-risk kids. That's why we're not having as good an outcome, is because we have that gap, and then the bacteria get in, and they're high risk. They're not cleaning it. They're eating the junk we know that kids eat all day. And we're going to get recurrent decay. And I've seen a little bit of that with Stella, but not quite at the rate I was seeing with the composites before. Unlimited depth of cure. This doesn't use a curing light. I was teaching my course in Minneapolis, which I'd like to invite you all to in November, but I was teaching this course and everyone was like putting the curing light on this Stella composite. I'm like, no, you don't need to do that. You just sit and you wait. It's a beautiful thing. You don't have to, you take out that air. I don't know how many times I'm probably curing a composite and you're doing something else looking the other way, and all of a sudden it's oh my God, the curing light's on the composite, and you're not getting that full depth of cure. You're not going to have that with the Stella composite. You can see strength is similar to some of these other popular ones on the market here for compressive and flexural strength. So you're not having to compromise in strength from using this material. It's going to be, again, here, a strong restorative material compared to some glass ionomers. And then you see SureFill 1 on there in the middle. So we're getting comparative results. All these products are well above the industry standards. So it's important to know that they're all great products to use. If you want to use whatever you're using, continue to use it. It's going to be free of a tertiary amine, so we're not going to get that yellowing that we talked about. I know we've had dental students that come through my office and they're like, "Doctor, I think we got recurrent decay, and then it's an RMGI that's turned yellow." And it's like, well, no, that's just part of the yellowing of the material from the tertiary amine that we have in the product. The restoration's still good. It just doesn't. It looks unaesthetic. So you're not going to have that problem with the Stella. You're going to be able to have all these chains form and just not have that shrinkage. So you're not going to post-op sensitivity with these. And you're going to still get the strength that you would with traditional composite, which you don't get with glass ionomers. Again, here's kind of the matrix that forms. It's going to be more uniform with these forming. You're not going to have gaps in it, and it's going to be a stronger restorative material than we've had before. Again, bond strength is really high with the primer. I talked about this. Like, if I'm doing back-to-back class 2s on primary teeth and I do them both at the same time, there is no way I can get that matrix band out without a hemostat. It bonds to the metal of the matrix band if I'm using that. And it can be frustrating, but I also know I'm getting a great bond strength to the tooth. So if you're going to be doing back-to-back with these, use 2 matrix bands, do them one at a time. If you don't want to use a hemostat, but you're getting a high bond strength, and you know you are. Like, you know, if you're doing it next to your crown, you're going to have something protecting that, or it's going to bond to the stainless steel crown next to it, and you're not going to be able to floss through it. It also does release the fluoride and the calcium and the strontium. Those are the bioactive properties of this material, which hopefully will help us prevent recurrent decay. We'll see more, hopefully, on this material coming out and how it does. I will report back to you and let you know in situations when it works and doesn't work, but so far I've been really happy with the results. These are just some cases that other doctors have done here. You can see Stella here, nice shade match here for this DO on this permanent tooth. Again, here in a class 5 restoration, a great shade match for this patient. This might be something that's traditionally done with a composite or with a GI, but now we have another material we can use for it. And then here, another class 2 restoration and class 1 restoration after finishing, just a nice aesthetic result for the shade matching. And I've been using this probably for about a year. Again, simple. Here's just a simple case. I did an OB here on this high-risk kid. This is a special healthcare needs child that took to the OR. Here again, you can see rubber dam isolation after caries removal. And then this is the initial set. It's going to appear a little more chalky, but after the final set, prior to finishing here, this is just coming back before finishing off that buckle. Here you can see a pretty nice match to the shade with the tooth, I would think, especially on one of these high-risk kids, to have a little bit more longevity and not have to do a stainless steel crown. Here, this is one of my first recalls that I was nervous about. I know nobody else tried a new product and you might be a little nervous about it. But here you can see here on tooth number L, just a simple DO. And here you can see a nice result. We're not having that wear that we get with the glass ionomer. And this is a 1-year recall in this kid. And I'm just excited to see where this will continue to go for me at my office. Again, here, this is tooth number I. You can see this is Stella again. Here you can see on the left the recall, just a nice recall. And this is a high-risk kid. They actually have more work to do. You can see incipient C on the mesial J. And then the other side of the mouth, we had some other things to work on today, but that was just something that came in today. Glass ionomers are great. I love GI. I love RMGIs. This is what I was using quite a bit prior. They just have a chemical bond to the tooth. They don't get recurrent decay like a composite does because of the micro leakage that we have. If you have something that's wet, it's going to be a little more moisture tolerant. You're not going to have issues with the bond to it. It needs actually water to set. So you're going to have probably a little better chance than using composite. Um, the huge disadvantage is just the strength. They wear more. I know we have some newer products on the market like Equia Forte and the Riva products, the iron glass, that do a little bit better job, but there's still going to be wear. And that's going to be a challenge, especially in these kids. We know a lot of kids grind their teeth these days, and that can be a huge challenge for us for restoration longevity. They're not the most aesthetic things. I mean, the shade it is what it is. They're a little more opaque. I think they're not as chromogenic as a composite is, but there are some things that are advantageous to it. And I think, and especially in these high-risk kids, this is why we're not getting recurrent decay. So this is the micro leakage study that I want done with the Stella. You can see this is just a glass ionomer here on the left on the top. And you can see compared to a flowable composite, you're not having that leakage. And I think that's why this is a great material for these high-risk patients, maybe some of these teens even, that we want to just get under control and go ahead and place glass ionomer to get them to a point where we can get their hygiene under control to get them be able to have a composite restoration down the road. RMGIs are a little bit stronger than a GI, and they're a lot more aesthetic. I do feel like these do have a little discoloration over time, but we're not going to see again that recurrent decay that we would be seeing with a composite restoration. So I think this is a great material. Typically in my class twos, when I've had to use this, if we've had a kid, they wear them down, I'm not really having to reprep much. We're just filling everything back up to where it was. And I think that's a great advantage to not have to have another procedure where you need to give a kid an injection and pick up the drill. I think aside from a stainless steel crown, it's probably one of the most preventive things that we can do for these posterior class twos and these high-risk kids is an RMGI. I think that's a great material selection. And I do have a little more strength. So this is just one example here. Here you can see this is here on tooth number S. You can see this is the problem that we have. I prepped way bigger than that, but we've had some wear and super eruption of the tooth. So you can see that this is probably not our ideal depth, but that's not what I prepped it to. So we're going to have that wear of these RMGIs that we're going to have to this may fracture here and we may have to replace that, but you can see we're not getting the recurrent decay. Again, another one here, you can see L and S here on these two teeth. This is a high-risk kid. We've got new decay here on I and B and A, and we're not seeing that in this and even on T. We're not even seeing any issues with our restorations that we place besides the wear. So again, in the kid that's a bruxer, this may not be the best choice, but you may want to consider this in these high-risk kids at your office. It works well, but with the caveat that you may have to replace some of these over time, and that may or may not require a handpiece, but typically we're able to fill things back up. Isolation is key. You may be able to do cotton roll isolation. I know a lot of us are doing art, sealants, or a class 1 restoration with this. I've really gotten back into the rubber dam with my microscope because it retracts everything. I get a better field of view with the microscope. And then you may also use like a dry shield or an isolite or a Mr. Thirsty at your office. I think those are great products. I think those make things so much easier because you're not fighting the tongue and you're not fighting the cheek. They all provide retraction. And I think you got to use whatever you're comfortable with and then also pair that with the material that you're going to use. Probably some of the best materials that we've implemented again are, the isolite and the rubber dam, and having the different sizes with the pedo for primary teeth. If we got a 6-year-old, we'll use a small, and then a medium for kind of some of those older kids. It's just nice to have that suction and the light and then the isolation. This is from the pediatric dentistry textbook with Art Nowak and Casamassimo, just comparing it a few different things. So they're both going to reduce aerosols, which we're all worried about with COVID. We're going to improve our visibility with both of them, protection from dropping an instrument or a matrix in the mouth. Some of these matrices now that they're really small, and we don't want to have that be an issue where a kid swallows it and we have to send them off to find out where those products are, if they're in the chest or if they're in the stomach. Hopefully they're in the stomach for us. But then we also have some differences in cost. So obviously if you're getting an isolite, you're going to be investing in that system that HVE that has a light on it and the suction, and that will increase the cost compared to a rubber dam. And then one of the disadvantages of a rubber dam is that you're going to have to deliver another injection. So you're going to have to deliver local anesthetic either through a papilla into the lingual to get that done, or on a gingival cuff to be able to isolate that tooth. That's not as big an issue in some of the older kids that are more cooperative, but if you're already have a kid that has a little higher pain sensitivity, that can be something that is a little more difficult to get through. I will say with the new C-clad devices, I use a woodpecker star pen. I know a lot of my colleagues are using the Soen from New Smile. Game changers for a local anesthetic. It becomes a little bit easier for you to deliver that injection comfortably and not have an upset patient. Again, tell, show, do. So a tooth ring, trampoline, raincoat. I use slit dam technique most of the time on kids, and I think it works really well. So selecting your rubber dam type, you can use one without a frame and add a frame, or you can use one that's already been framed. We'll typically do a Mickey Mouse punch here on the holes. And I typically don't extend that and cut like this picture is showing. I just will typically use the Mickey Mouse slot and put that offset and have a few of them ready. But it's super simple to go ahead and then stretch that rubber dam over the tooth and have an isolation for that field. I would also make sure that you are considering with your treatment planning, the restorative considerations, the size of the cavitation, the extent, how deep it is, how long till exfoliation. I mean, we may have something that we probably would not do a class 2 on in the situation where it's a large decay, but it's an older kid and they don't need it forever. So we're not going to jump to the crown. We're going to go ahead and do the class 2 because we don't know it only needs to last a year or two. But if we leave that, we're going to end up doing an extraction within a year. So keep those things in mind. Patient cooperation. Obviously, if it's more difficult, you may want to have the glass ionomer ready to bail you out if that's the case. I'm going to move into some preparations, but let's cover. So class 2 restoration. So proximal caries detectable by radiographic detection only has been what we've been traditionally planned these for. So like if you see a DO and it's clinically evident, typically it's been recommended that should be a stainless steel crown or a zirconia crown. Now I will say that may not always be the case. Like we just covered, you may want, if they don't need the tooth for more than a year or two, you may want to just go ahead and do the class 2 and save a little bit of headache from the parent of, oh my gosh, I need a crown. And they think the crowns are $1,000 when they're not really $1,000. It's not like a permanent tooth. And then your case acceptance go down and they're back in your chair for an extraction in 6 months. You may want to consider also on a mesial surface of a first molar. We know those don't do too well with class 2s. You may want to consider a crown in that situation. Again, if you have a carious lesion and it's an MOD or 3 surfaces or greater, you may want to consider a crown. Really young kids, I mean, the tooth's only been in the mouth for a year, 2 years, and they already got decay. What's the chance that we're going to be working on that again? Think about caries risk in that conversation. And if they're not compliant, they don't show up to your office. They came in for an emergency and you're doing a tooth next to it and they have never been to the dentist, that may be something you want to consider doing that other tooth, a crown versus a class 2 if they have a poor track record. Here you can see just on this bite wing, you probably are going to be having a little bit more conversation about crowns with this kid than you would be with this one. So this one's got an mesial lesion. This is probably something that I'll reevaluate. When we move into lesions more like this is when I'm on A and B, more likely to jump in for treatment. And if this kid's cooperative, we're going to work with this kid on hygiene on S and T. Unless we're doing sedation, I'm not jumping into those. I've gotten a little more conservative as I practice, and especially on these kids that are cooperative, we try to give them a little bit more time and work on hygiene and prevention. And I mean, obviously, I've got some kids that do really great with that, and we don't work on these till they fall out. And we've got some kids that these progress on, maybe 1 or 2, and we're working on them again. Here's kind of our restoration design. So I am more of like the JV Black on primary teeth. I know there's newer ways to do things with the modified presentation. So you're going to want to go ahead and extend with these restorations. I think especially with amalgam and arms, GI and GIs, you're going to want to extend these into the grooves, and that's going to give you more retention. We talked earlier about anatomy and mineralization, and we don't have as much mineralization as we do in a permanent tooth, so we need a little bit more to bond to. So we're going to open that up and get a little more mechanical retention to get that bond to. We don't want to have a reverse S-curve. And then just make sure you're breaking your proximal contacts, especially with your matrix. That makes it so your margin is cleansable and that you have room for your matrix band and your wedge can fit. So be able to open those up. This is the modified preparation that a lot of people are doing now. So it's not as extensive, more conservative, more like a slot preparation with adding a little bit of retention on the occlusal surface. And then for composite, not GI or arm GI, you're going to want to place a bevel around all the margins, so that way you can open up those enamel rods to bond to. So this is something that you can do. I'm more the traditional way. If you like doing this, if you can do this skillfully with your composites, I would encourage you to utilize this preparation. It's a valid technique that's being taught. Again, you want to make sure you break your contact, explore tips enough, and that's just going to make sure your margin gets cleansable and you have room for your matrix band. You definitely, especially with some of these matrices I'm going to show you today, you need to have your contacts open or you're not going to be able to fit your matrix band. Your proximal box should have a pendulum swing to it. This is just going to, one of the problems is if you get extended too far occlusally, then you get to the point where you've already broken up and you're past the line angle and you weaken the tooth so much that it's going to fracture. And the worst thing that you can have happen with your class 2s is to have the tooth fracture, and then you're coming back and doing a pulp and a crown when you could have avoided that. And that's why these are so challenging. We don't have a lot of real estate to work with. We are working in very tight spaces on these primary teeth. And that's why this is one of the most difficult and technique sensitive procedures, I think, in pediatric dentistry. I'm going to move on in lieu of time and get to some of, I want to be respectful for questions and things. Just some of our, let's see, I've got these all the time. So just some matrices. So a de novo band, if you're going to use these are great. The problem with these is your anatomy is not going to be as pretty as if you use some of the other systems out here. Primary first molar, a 3 or a 4, and then a second molar, usually a 7 or 8 will work for those. So placing the band and then your wedge. T-bands are popular. They're a little more cost effective, but they are a little more work, similar to the de novo band. Here you can see restorations with some of these. And you can just see the flat occlusal, just not as aesthetic as you would like with these. They don't have the contour that you'd like to have with a sectional matrix. This new product I'm really excited about. I got to test it out a little bit on a Typodont, and now I've been using it in my office. This is the Octowatrix, and it's a wedge, a matrix, and then it also forms a marginal ridge former. So you're going to essentially have this take the place of a sectional matrix system for primary teeth. And it's given great contour. It's going to have less work. I've really enjoyed using this product at my office. It's going to make it so much faster for you to do these restorations. You're not going to have a big kit of de novo bands to do this. It's a one size fits all. You just have a right and a left, and you pick it out based on where it is in the mouth. The biggest thing is practically if you do this right, you really don't have to do too much finishing on this product. It's like I said with the Stella, it shortens your working time with these kids. You take it out and you may just have a little bit to adjust on the occlusal surface. And that's been really exciting. And then also it forms a really nice seal on the gingival. So you're not going to have that leakage from the gingiva coming up. I know that's one of the things I've struggled with the de novo bands and the wedges is you get that bleeding coming up and you're trying to be assistant to rinse it off. And it's just a constant problem. And then this is going to solve it because it just forms a nice tight seal. It's also transparent. So you're going to be able to go ahead and have a good depth of cure if you're using a light cured material. I'm going to go ahead and play this video here. And while we're looking at things, we've had some questions come through. So this is placement of a rubber dam here. Here we did a class 2 in another area of this child's mouth. And we're going to go ahead and this was planned for I think an MODO on L and S. And we're going to go ahead and just do one of those quickly here with you. with our class 2 preparation. So again, using the slit dam technique here, usually like to wrap that over the canine. And we're going to start with tooth number L here. And we're going to go ahead and use the octawatrix. So I'll usually start preparing the tooth from the occlusal surface. I am more that GV black kind of preparation for class 2s on primary teeth. So I feel like that helps me manage that marginal ridge and then also be able to move into that decay so I can kind of see where I need to drop my box down. So I'm making sure that I'm not dropping down and then trying to have to level up again. I just don't want to have to go back and have my box get too deep. And it's really helpful to me to be able to see that decay. I like to use a 330 burr. I know some of my colleagues like a 245, but I'm more of a 330 and extra short one here. I've kind of moved a little bit to a longer shank with some of the other burrs, but here you can see I'm leaving that ridge intact just until I want to brush that out. And you can see the decay there in the mirror that we're able to now visualize and be able to come in and drop down. So here you can see kind of the pendulum starting to swing back and forth with the burr just to kind of keep that. And I'm trying to keep within so I'm not dropping out and getting so far divergent with the occlusal part. That way we maintain the integrity of the tooth. So again, I'll just work my way down again, trying to take this very carefully. And this is such a precise procedure. And you can see, obviously we have a sedated patient here, but it's just so difficult to do. I think David Rothman said dentistry on kids is like trying to change a tire on a car that's moving 30 miles an hour. So that's just how simple this is to place, the octawatrix. And you can see how we've got our wedges, we've got our marginal ridge former, and the matrix. So here we're going to be using Stella composite. We're going to go ahead and dry the tooth off. And this is the primer. So this is going to be the primer that has the MDP that needs to sit on the tooth for 5 seconds. So we're going to go ahead and apply that with the micro brush. And one of my tips for you is just to save that micro brush because we can use that to adapt the Stella material because it's a flowable composite. So this is the drying after the 5 seconds. And we'll come in, this is a capsule. You can see that's a little bit thicker. So the tip you use for the auto matrix or the auto mix is a little bit different than that. It's gonna be a little thinner. So if you have a deeper preparation, you can see how that may not fit down there. So I'll overfill the preparation so we have enough material. And then the micro brush, my assistant will hand that right back to me and we'll go back and we'll be able to clean that up. And then this is about 120-second set time. So we'll just let that go after we get that done. And we'll go ahead and remove that matrix after that amount of time. So we'll sit there. I like to extrude any excess out onto my glove. And once it's hard, I'll remove that matrix. So you can see we're going to go ahead and remove that matrix. And you might get a little bleeding from the gingiva when you do this. If you're doing back to back, you'll have to do it separate. That's not going to be an issue with the gasket seal that you have. I haven't had an issue with keeping things dry. And you can go ahead and then start finishing this after that. Minimal finishing. Here you can see just doing a little a marginal rigid reduction where I had a little too much. And then I'll come in while this is still kind of in that initial set time, you got a little bit excess there towards the mesial of the tooth. I'm going to get that with the cleoid and that should set up just fine for this patient. So again, it's just that simple to be able to place this and minimal finishing. You can see really nice contour, a little bleeding from the gingiva from the matrix placement, but just a great result and a lot easier to do than coming back with the de novo band. This is from Dr. Jensen. If you haven't listened to our podcast, go ahead and listen to that on pediatric dentistry from A to T, but this is a smart technique. This patient wanted to avoid a stainless steel crown. Obviously, this would be a great candidate for a hollow crown, but here we can see a nice result and you can see nice contours even with this GI. And we know that if we don't put that GI in there or we don't crown the tooth, that this is going to get food impaction and we're going to be dealing with the bigger problems. So this is a great way a great service for our patients to be able to, you know, kick this down the road and not have to deal with a lot of issues. We're down here to just a few minutes. I don't use a lot of these on primary teeth. I think it's a lot to have in the kid's mouth when you talk about a small sectional matrix, a ring, and then a wedge all at once. I think the octawatrix is a great solution to this problem, but this is a great way that I like to work on permanent teeth with these. In lieu of time, I'm going to move past That's the Garrison sectional matrix system that I use at my office. And we'll move down here into, I know we're supposed to cover polishing. These are the ones I like. I like Ultra Dense Jiffy polishers. The green will actually remove a little bit of tooth material, and the others will polish. So if you're looking at a system for that, that's what I like to use. They're autoclavable. They've got great shape. Really got introduced to these in dental school and fell in love with them, and I still use them today. Most information tonight's from pediatric dentistry, and I do have a special promotion here. If you are interested in a free sample of the Octowatrix, we do have that here. Scan this QR code and they can get you a free sample of the product. If you're not interested in the free sample and you want to try this hands-on with me in Minneapolis, we'd love to have you at our course with pediatric dental seminars on November 8th. And it's a great facility up there. We have microscopes for everyone to use if you want to try that out with your ergonomics and see how that works. I just got started with that. I think it's an exciting journey for me to work on my posture and then also provide better quality care for my patients. But an exciting facility up there. It's like they've got all this stuff like back in dental school. It's not like you're working at a hotel situation. We're going to do a lot of great things with zirconia crowns, stainless steel crowns, Hall crowns, class 2s. We do it all at our course. So I would like to thank everyone for coming. I'm going to go ahead and answer some questions. If you have any questions, you can go ahead and put them in the Q&A and we'll get this recording up. Again, your CE certificate, if you registered and you were on the webinar for a long enough period of time, that will get emailed to you here shortly. So let me look at some of these questions that are coming through. Okay, GI class 2 restorations I place tend to come off more frequently than composites. Do you have any advice for making GI restorations more retentive? I think for me, I struggle with that too. And I think the biggest thing is you have to have adequate bulk for it. So you have to have it prepped like an amalgam. And that's a lot of tooth structure removal, I know, but that's what I found that's worked the best for me. Is my best GI ones and RMGI ones are when I have adequate bulk and strength from material. We know it's going to wear over time. And obviously, I feel better in a high-risk kid placing the GI than a composite because we're not getting recurrent decay. I mean, I just have they come back and it's like, where there's a ghost restoration, there's nothing there. So I feel a lot better in the high-risk kids. I don't feel guilty about that. I think it's a great service to, if they don't want to do the crown in a high-risk kid, to go ahead and do the GI. But bulk, having it prepped like an amalgam is going to be what's been best for me. What are your thoughts on Activia Bioactive Restorative? I think it's a great product. I think a lot of people got burnt out on it because they told you don't need to do a bonding agent. And it really does need to be treated like a composite. When I've treated it like a composite, it's done well. It's not a product that I use a ton right now. I'm using a lot of the Stella product that we talked about tonight. But I think it's a product, if you use it per the IFUs where you do the etching and the bonding, I think you can have great success with it. Can you reuse the Octowatrix on subsequent teeth the same patient? Yes, you can. I would not recommend using it. It's similar to any other matrix thing. You wouldn't want to use it on multiple patients. Obviously, if you have a de novo band and you're doing one on B and one on S, and it's the same 3 or 4, I use the same one if it's not bent. And you're going to be able to do that. You're going to have to make sure you use either the right or the left one. So you may have different areas of the mouth you're working on. They may be a different right or left. So it may not work for you depending on the situation. But if you have 2 different ones that match up and it's a left and a left or a right and a right, you definitely can reuse it. And then I think they are recyclable too. Can you use 2 at the same time, 2 Octowatrix at one time on an MO or DO? No, you cannot. That'd be a little too much to fit between the teeth. And that is one disadvantage, that you may be used to doing a MO or a DO next to each other with 2 different de novo bands and a wedge, but you're not going to be able to do that with the Octowatrix. But you're going to also not have the same properties that you have with the Octowatrix. You're not going to get the seal. You're not going to get the margin of ridge former. You're not going to have the reduced time in finishing. So when you look at doing one and then the other, you may be adding a little bit more time, but you're going to save a little bit of time with not having to do all the finishing that you've had to do in the past. So that definitely is one of the challenges. And I'm sure Chad and his team are well aware of that. But I think it's a great product that I've really been impressed with. And it's not all the time that I'm doing back-to-back MODOs on these kids either. So it's not always as big of an issue. Let's see if there are any other questions here. I'm going to check the chat. Nothing in the chat. So I appreciate everyone joining me tonight and having a good time. I know we had a little more content that I didn't get to everything that we wanted to, but I hope that you had a wonderful time learning about some new products. And I would hope if you're interested in trying this out, we'd encourage you to do that. And I'd like to thank Octodent for the support as well. And I hope that you all have a wonderful week and are happy to have the kids back to school. I'm happy to have a little bit of a break. So again, if you're interested in any of our content through pediatric dental seminars, go ahead and subscribe on our website to our email list, tune into the podcast and look for more upcoming webinars. We'll try to do some more here for you and then try to get the study club going back up again, hopefully here shortly. So again, thanks for coming in and I hope you have a wonderful evening.